What if the constant ringing in your ears isn't just age or stress or permanent nerve damage, but a fungus quietly living in your ear canal, stirring up inflammation and noise? That possibility is rarely discussed, yet for a subset of people with tinnitus, a fungal ear infection, otomycosis, can be an overlooked contributor. And while nothing here promises a miracle, there's growing laboratory and preclinical interest in one herbal compound that may help when used the right way: olive leaf extract, whose active ingredient oleuropein has documented antifungal and anti-inflammatory properties in controlled settings. Before you try anything, though, understand this: fungal infection is only one of many possible causes of tinnitus, and olive leaf is not a proven cure for ringing ears. It might, in select situations and under professional guidance, be a useful adjunct. In this video, I'll walk you through what tinnitus really is, how a fungal infection could produce or worsen it, what olive leaf does on a biological level, how clinicians diagnose and treat otomycosis, and how you might responsibly explore olive leaf as part of a broader care plan, always with ENT confirmation first. If you want evidence-focused natural health breakdowns like this, hit subscribe and stay with me through the details. This could change how you approach your own symptoms. Tinnitus is the perception of sound when there is no external source: ringing, buzzing, hissing, whooshing. For many people, it's intermittent. For others, it's constant and disruptive. It's common. A large number of adults will experience tinnitus at some point, and for a smaller group, it becomes chronic and life-altering. Clinicians typically sort tinnitus into broad categories. Sensory neural tinnitus is linked to damage or maladaptive activity in the auditory nerve or inner ear structures. Think age-related hearing loss, noise exposure, or ototoxic drugs. Conductive tinnitus comes from physical changes in the outer or middle ear that affect how sound is transmitted. Somatic or cervical influences show how neck and jaw problems can modulate tinnitus. Systemic causes, metabolic, endocrine, vascular, also play roles in certain cases. The point is this: tinnitus is a symptom, not a diagnosis. Finding the correct underlying cause is the essential first step toward meaningful relief. Now consider an under-discussed possibility: a fungal infection of the ear canal. Most people think of bacterial ear infections or earwax when they imagine ear problems, but fungi, commonly species of Aspergillus or Candida, can colonize the external auditory canal and create an inflammatory environment. This condition, otomycosis, is more common in warm, humid climates and among people who swim frequently, use hearing aids, take broad-spectrum antibiotics, or have chronic skin conditions. Diabetes and immune suppression also raise risk. The point is this: tinnitus is a symptom, not a diagnosis. Finding the correct underlying cause is the essential first step toward meaningful relief. Now consider an under-discussed possibility: a fungal infection of the ear canal. Most people think of bacterial ear infections or earwax when they imagine ear problems, but fungi, commonly species of Aspergillus or Candida, can colonize the external auditory canal and create an inflammatory environment. This condition, otomycosis, is more common in warm, humid climates and among people who swim frequently, use hearing aids, take broad-spectrum antibiotics, or have chronic skin conditions. Diabetes and immune suppression also raise risk. The classic symptoms of otomycosis include itching, flaky or dark discharge, sometimes a feeling of fullness or decreased hearing, and discomfort. Importantly for our focus, the inflammation, debris, and local irritation that fungi cause can produce or amplify tinnitus in some people. How might a fungus lead to that persistent ringing? There are several plausible pathways. First, physical obstruction. Fungal filaments and debris can partially block the ear canal or cling to the tympanic membrane, changing the acoustics and creating abnormal stimulation perceived as noise. Second, inflammation. Fungal organisms elicit an immune response that releases inflammatory mediators. And inflammation near delicate ear structures can sensitize local nerves. The auditory nerve endings can interpret irritation as sound. Third, secondary changes. Persistent fungal colonization can alter just enough of the local environment to change the way the ear transmits and perceives sound, especially if there are fluctuating levels of moisture and material in the canal. Clinically, there are case reports and clinic observations where patients with Otomycosis noticed either new onset or worsening of tinnitus that improved after targeted antifungal treatment. The literature here is limited and often observational, so we label specifics as indefinito, but the biological story, obstruction plus inflammation leading to altered auditory perception, is coherent and plausible. Recognizing Otomycosis requires a careful ear exam. A trained clinician will use an otoscope or microscope to look for characteristic signs: fungal hyphae, often appearing as powdery, cottony, or dark material, flaky skin, and inflamed canal tissue. Unlike simple earwax, fungal material can be discolored, white, black, gray, or brown, and stubborn when you try to remove it. An ear swab from microscopy and culture can help identify the fungus, although cultures can be imperfect. In practice, ENT specialists often combine visual diagnosis with targeted cleaning, microsuction or gentle debridement, and topical antifungal therapy when appropriate. In cases with a perforated eardrum or middle ear involvement, systemic treatment or more advanced care may be necessary. Crucially, if you suspect Otomycosis, do not try to probe the ear with cotton swabs, ear picks, or liquids unless directed by an ENT. Such actions can push material deeper, injure the eardrum, or complicate diagnosis and treatment. So where does olive leaf extract fit into this picture? Olive leaf, the traditional botanical derived from Olea europaea, contains several polyphenolic compounds, and the most discussed is oleoropin. Laboratory studies demonstrate that oleoropin and related olive-derived polyphenols exert antifungal activity in vitro against a range of fungal species. These same compounds show anti-inflammatory and antioxidant effects in cellular and animal models. Olive leaf could be discussed as an adjunct, taken orally to potentially reduce systemic or local fungal burden and to modulate inflammation, or considered in a topical formulation only under medical supervision when the tympanic membrane is intact and a clinician has approved such use. Importantly, topical application in the ear without confirmation that the eardrum is intact is risky. Never put liquids, oils, or unverified topical agents into the ear if you have an unknown or likely perforated eardrum. Safety is a central theme here. Olive leaf is generally well tolerated in many people when taken at typical supplement doses, but it is not risk-free. Potential interactions exist. Olive leaf constituents can have mild blood pressure lowering effects and may interact with anticoagulants or antiplatelet agents, so people on blood thinners should consult their clinician before starting any olive leaf product. Those who are pregnant or breastfeeding, people on immunosuppressants, people with advanced liver or kidney disease, and those with uncontrolled diabetes should be particularly cautious and seek medical advice. If you have a known perforated eardrum, are experiencing severe ear pain, sudden hearing loss, discharge with a foul smell, fever, or dizziness, you should seek urgent ENT care rather than attempting home remedies. Also, avoid applying topical olive leaf products into the ear canal unless a clinician has confirmed the eardrum is intact and has provided guidance. Topical substances can travel into the middle ear if the tympanic membrane is compromised. It helps to know what signs should raise your suspicion for otomycosis versus other causes of tinnitus. Key red flags for fungal involvement include persistent itching deep inside the canal, flaky or colored discharge that looks different from routine earwax, visible cottony or powdery fungal material on otoscopy, a history of frequent swimming or exposure to humid environments, recent prolonged antibiotic use, which can disrupt normal flora and allow fungi to flourish, hearing aid use with poor hygiene, and systemic risk factors like diabetes. If tinnitus appears or worsens in the context of these signs, bring it up specifically during your ENT visit. Request careful inspection and, if warranted, an ear swab for fungal microscopy and culture. Remember that negative cultures do not always rule out a fungal contribution. Sampling can miss organisms, which is why clinical judgment and direct visualization are so important. I want to pause here with an important clinical caveat. While antifungal agents prescribed by an ENT remain the standard of care for confirmed otomycosis, some patients search for adjunctive, natural options because they are concerned about side effects, accessibility, or recurrence. For those people, olive leaf can be presented as a companion strategy, not a replacement, and only after confirming the basics: intact tympanic membrane, identified fungal involvement, and clinician oversight. In-office debridement to remove fungal material often provides immediate symptomatic relief because it eliminates mechanical irritation and debris that can be causing sound distortion. Topical antifungals then reduce the remaining fungal colonization. Oral adjuncts like olive leaf could theoretically help by reducing fungal loads systemically or by modulating inflammation, but again, the evidence is preliminary. Let's translate that into a practical checklist a patient could discuss with their ENT. First, get a proper otoscopic exam and, if indicated, an ear swab for microscopy culture. Second, ask about professional cleaning options, microsuction or careful debridement to remove visible fungal material. Third, discuss prescription topical antifungals and the expected course of therapy. Fourth, if you are interested in olive leaf as an adjunct, ask whether it's reasonable in your case considering your ear exam and overall health. And fifth, if approved, choose a product with standardized olorupin content, independent lab testing, and a transparent label, and inform your prescribing clinician or pharmacist about the product to screen for interactions. Now, to be scientifically honest, what does the evidence actually show about olive leaf for fungal ear infections and tinnitus? The strongest findings are in laboratory settings. Olive leaf extracts and olorupin inhibit growth of multiple fungal species in vitro, and they reduce fungal adhesion and biofilm formation in model systems. Animal studies indicate reduced fungal burden and dampened inflammatory markers when olive leaf compounds are administered in experimental infections. Human data are much thinner. A smattering of case reports and small observational reports suggest symptom improvements in certain fungal-related conditions after olive leaf use, but these are not randomized controlled trials and often lack standardized endpoints. For tinnitus specifically, there is no robust clinical trial showing olive leaf cures or reliably reduces ringing. Therefore, any claim that olive leaf cures tinnitus would be unsupported. We must use language like may, might, suggests, and indefinite to reflect these uncertainties. At the same time, the biological plausibility and preclinical findings do justify clinical curiosity and carefully monitored trials. Given that uncertainty, how do clinicians balance innovation with caution? Many ENT specialists and audiologists adopt a tiered approach. Treat confirmed fungal infections with established methods, consider adjunctive low-risk supplements after discussion, avoid unregulated topical experimentation in the ear, and monitor outcomes closely. If an adjunct like olive leaf is added, clinicians watch for improvement in symptoms, monitor for adverse effects or interactions, and maintain readiness to escalate to prescription therapies if the clinical picture does not improve. This respectful combination of openness to natural compounds and adherence to evidence-based core treatments is the prudent pathway. There are also practical product considerations worth knowing. Not all olive leaf supplements are created equal. You'll commonly find extracts standardized to deliver specified percentages of oleuropein. For example, some products advertise 10–20% oleuropein, though percentages vary. A higher percentage does not automatically mean better. Formulation, bioavailability, and purity matter. Third-party testing, verification by independent labs that checks for contaminants like heavy metals, pesticide residues, and microbial contaminants, is a quality marker you should look for. Reputable manufacturers will share certificates of analysis or testing badges on their websites. Transparent allergen labeling, clear dosing instructions, and a return policy are additional signs of a trustworthy company. Pharmacists can help evaluate product safety and potential interactions with your medications. It's also worth acknowledging why fungal ear problems can be underdiagnosed. Otomycosis can be subtle and episodic. Patients may self-treat with over-the-counter ear drops or try to clean ears at home, which can temporarily mask symptoms without addressing the root cause. In some clinics, fungal infections are mistaken for dermatitis or chronic earwax, particularly when the clinician doesn't perform ear microscopy or cultures. Moreover, patients with primarily auditory complaints like tinnitus may not mention itching or discharge unless specifically asked. That's why a detailed history is crucial. Ask your provider about swimming habits, recent antibiotic use, hearing aid hygiene, occupational exposures to moisture, and whether you've noticed any itching, smell, discharge, or visible debris in the ear. I mentioned earlier that olive leaf has both anti-inflammatory and anti-mottle actions in lab models. To make that idea tangible without overstating it, imagine the ear canal as a small, delicate garden. When fungi colonize, they don't just sit quietly. They disturb the soil, crowd the space, and set off local alarms. The immune system responds and inflammation rises. That inflammation can be noisy, not literally, but in the way nerves pick up altered signals and interpret them as sound. Olive leaf compounds, in lab experiments, have acted like a gardener who both suppresses the overgrowing molds and soothes the soil's inflammatory response. That double action, limiting fungal growth and calming inflammation, is why researchers find olive leaf biologically interesting.
Still, translating that metaphor into real ears with complex anatomy, variable absorption, and the question of whether topical or systemic application gets enough active compound to the infected site is the clinical challenge. Before we move deeper into practical protocols and a short illustrative anecdote, it's important to reinforce contraindications and safety flags. If your eardrum is perforated, do not permit anyone, including yourself, to put oils, tinctures, or supplements into the ear canal without an ENT's explicit approval. If you are pregnant, breastfeeding, on anticoagulants like warfarin, taking antiplatelet drugs, immunosuppressive therapy, or have unstable medical conditions such as uncontrolled diabetes, check with your healthcare team before starting olive leaf. Seek urgent or same-day attention for severe ear pain, sudden hearing loss, significant dizziness, or foul-smelling discharge accompanied by fever. These signs can indicate more serious middle ear disease or complications that require immediate medical treatment. So what does a reasonable clinician-supervised trial look like if fungal otomycosis is diagnosed and you want to explore olive leaf as an adjunct? The responsible sequence would typically be professional ear cleaning to remove visible material, initiation of ENT-prescribed topical antifungal therapy if indicated, discussion of systemic adjuncts like olive leaf with your physician, especially to screen for interactions, and close follow-up to assess symptom trajectory. If you're recommended an oral olive leaf product, choose a standardized extract from a manufacturer with third-party testing. Keep a symptom diary. Note changes in tinnitus intensity, hearing, itching, discharge, and any systemic side effects. If there is no improvement or if symptoms worsen, discontinue the supplement and return to your ENT for reassessment. Anecdotes exist in the clinical world. Patients who had persistent tinnitus and ear itching were found on examination to have fungal debris in the canal. After debridement and targeted topical antifungal therapy, sometimes combined with an oral herbal supplement such as olive leaf under supervision, they reported a decrease in ringing. These stories are powerful and meaningful on an individual level, but they are not randomized evidence, they are illustrative. They highlight the importance of accurate diagnosis and targeted therapy. Labels like anecdote or case observation are important so we don't mistakenly generalize from a few stories to a universal truth. At this point, you may be wondering about the timing and expectation setting. If otomycosis is the culprit and it's properly treated, how quickly might tinnitus improve? The honest answer is, it varies. For some people, removing the physical obstruction and calming the inflammation can produce rapid relief within days to weeks.
For others, if tinnitus has central nervous system components or is multifactorial, improvements may be partial or slower, requiring adjunctive therapies such as hearing rehabilitation, sound therapy, or cognitive strategies. This variability underscores the need for comprehensive assessment and a multimodal plan. Before I continue with precise steps you can take, product selection guidance, and a brief anonymized case vignette illustrating the diagnostic arc and the way olive leaf was incorporated under medical supervision, let me summarize the key takeaways so far. Tinnitus has many causes. Otomycosis is a possible and often overlooked contributor. Fungi can cause tinnitus through obstruction and inflammation. Olive leaf shows antifungal and anti-inflammatory activity in laboratory and preclinical studies, but has limited clinical data for otomycosis-related tinnitus. NT evaluation and targeted antifungal therapy remain primary, and olive leaf may be considered as an adjunct with professional guidance, attention to product quality, and careful monitoring. Now, let's step into more practical territory, what to expect during an NT visit focused on this question, and how a clinician might work through diagnosis and treatment, and then we'll look at a short illustrative example of how this can play out in real life. During an NT visit focused on this question, expect a methodical, stepwise approach rather than a quick band-aid. Your clinician will first take a focused history, not just about the ringing, but about ear habits and exposures. Do you spend a lot of time in pools or warm, humid environments? Have you recently completed a course of broad-spectrum antibiotics? Do you use hearing aids or earbuds frequently and clean them regularly? Have you noticed itching, discharge, reduced hearing, a bad smell, or visible debris? These seemingly small details steer the exam. The provider will then perform careful otoscopy, often with magnification, to look for visual clues: flaky or powdery material lining the canal, discolored deposits, inflamed skin, or fungal-looking growth that appears cottony or dark. If the eardrum is visible and intact, they may take a swab from microscopy and culture to try to identify a fungal organism. Keep in mind that cultures are helpful but imperfect. A negative culture does not always rule out fungal involvement because sampling can miss organisms or lab methods vary. So clinicians balance laboratory results with what they see directly. If the clinician suspects otomycosis, the next practical step is often professional cleaning. That might be microsuction, careful debridement, or irrigation performed by an experienced provider with visualization. Removing the bulk of fungal material frequently produces immediate symptomatic relief because it clears the mechanical irritation and the change in acoustics that can contribute to tinnitus. After cleaning, most ENTs will prescribe or recommend a topical antifungal treatment when appropriate, applied by the clinician or given as an eardrop or powder formulation to be used under strict guidance. In selected cases where the infection involves the middle ear or the tympanic membrane is perforated, systemic antifungal therapy or more advanced ENT management may be necessary, which is why timely evaluation matters. Where olive leaf might enter this clinical pathway is as a cautiously considered adjunct. Discussing olive leaf with your ENT should happen after the initial exam and after the clinician confirms the eardrum is intact. If they agree it's reasonable, olive leaf could be used as an oral supplement to potentially help reduce fungal burden systemically and modulate inflammation, or, rarely and only under direct medical supervision, as a topical agent designed for otologic use. Again, topical application into the ear should never be attempted without an ENT's explicit permission because of the risk of middle ear exposure if the tympanic membrane is compromised. Practical product selection matters. When evaluating olive leaf supplements, look for products that state a standardized oleoropin content on the label. Manufacturers commonly standardize extracts to a range of oleoropin, and values you might see vary. Many reputable extracts fall into a percentage range intended to ensure consistent active compound delivery. Third-party testing is an important quality marker. Independent laboratory analysis that checks for purity, verifies oleoropin content, and screens for contaminants like heavy metals or microbes increases confidence in the product. Transparent manufacturers will publish certificates of analysis or allow you to request them. Avoid supplements with vague ingredient lists, proprietary blends that obscure quantities, or dramatic marketing claims about curing infections or tinnitus. If you plan to combine olive leaf with prescription therapies, consult a clinician or pharmacist so they can screen for potential interactions. Safety and interactions deserve a clear standalone emphasis. Olive leaf is generally tolerated by many people, but it can cause side effects such as mild gastrointestinal upset, headaches, or allergic reactions in sensitive individuals. Biologically active polyphenols can interact with medications. Olive leaf may modestly lower blood pressure and could theoretically interact with antihypertensives, and it may have additive effects with anticoagulants or antiplatelet drugs, increasing bleeding risk. For that reason, people on blood thinners, on multiple cardiovascular medications, pregnant or breastfeeding people, those with severe liver or kidney disease, people on immunosuppressive regimens, and individuals with uncontrolled diabetes should consult their clinician before starting olive leaf.
Always tell your ENT and prescribing physician about any supplement you are taking so they can advise on safety and monitoring. Monitoring is part of a responsible trial. If your clinician approves an oral olive leaf supplement as an adjunct, agree on a plan with clear checkpoints. A baseline symptom assessment, objective findings on exam, and scheduled reassessment within a defined time frame. Keep a symptom diary that records tinnitus intensity, for example giving it a scale of 0 to 10 each day, episodes of itching, changes in hearing, presence or absence of discharge, and any side effects you notice after starting the supplement. If you observe increased bleeding, unexpected bruising, significant blood pressure changes, new neurological symptoms, or any worsening of ear pain or discharge, stop the supplements and contact your clinician promptly. If the tinnitus does not improve within the agreed period, or if symptoms worsen, return for reevaluation rather than persisting indefinitely on a self-directed regimen. Let's be realistic about expectations and timelines. For people whose tinnitus is primarily driven by mechanical irritation or local inflammation from fungal debris, the most pronounced relief often comes after professional cleaning and effective topical therapy, sometimes within days to a few weeks. If olive leaf contributes, it is more likely to do so gradually by reducing inflammation or helping control fungal overgrowth systemically, and any benefit would typically be modest and take longer to assess. For individuals whose tinnitus involves central nervous system changes or multiple contributing factors, noise-induced hearing loss, vascular conditions, TMJ dysfunction, and so on, improvements after treating otomycosis may be partial and slower. That variability is why NT-guided multimodal care, combining appropriate medical therapy, a realistic timeline, and adjuncts used under supervision, is the safest route. Special populations need extra care. If you have diabetes, especially poorly controlled diabetes, the risk of fungal infections increases and healing can be slower. Coordinate closely with both your ENT and your primary care provider. If you take anticoagulants, such as warfarin or direct oral anticoagulants, have a bleeding disorder, or are on antiplatelet therapy, discuss the possible bleeding risks with your team before starting olive leaf. Pregnant or breastfeeding individuals should generally avoid starting new herbal supplements unless a trusted provider advises otherwise. Children and adolescents require pediatric ENT input. Do not attempt adult formulation dosing based on extrapolation. People with known severe allergies to olive or related botanicals should avoid olive leaf. Now let me share an illustrative anecdote to ground this pathway in a real-world feeling example. This is labeled clearly as an anecdote, not as broad evidence, but it captures how the steps I've described can play out. A middle-aged woman I'll call L had persistent right-sided tinnitus for nearly 8 months. It started after a summer of frequent lake swimming. She also noticed intermittent deep itching and a faint musty smell from that year. But because the ringing was so loud, she focused on that symptom and delayed an ENT visit. Her primary care doctor had tried an over-the-counter ear drop and then a brief course of oral antibiotics for presumed bacterial otitis, but the symptoms persisted. When Elle finally saw an ENT, the microscopical exam revealed cottony, dark material lining the canal and an inflamed canal skin. The tympanic membrane was intact, but the fungal-looking debris was obvious. The ENT performed microsuction to remove the bulk of the material, swabbed the canal for microscopy and culture, and started a short course of ENT-prescribed topical antifungal drops.
Because L had a history of hypertension controlled on medication and asked about an herbal adjunct, the clinician reviewed potential interactions and approved a monitored short-term trial of a standardized olive leaf oral extract, provided the product contained a verifiable olorupin standard and third-party testing. L kept a symptom diary and returned for a one-week follow-up, at which point she already noticed reduced itching and a modest decrease in the perceived loudness of the tinnitus. At 2 weeks, she reported a clinically meaningful drop in the intensity of the ringing, which she attributed primarily to the initial debridement and the topical therapy. She and the clinician both felt the olive leaf might have aided the inflammatory recovery, but could not attribute the improvement solely to it. The culture later grew Aspergillus species, and the ENT completed the topical course while maintaining monthly follow-up. L's tinnitus continued to improve over 3 months, and the olive leaf supplement was tapered off after consultation with her clinician. This single case does not prove efficacy, but it illustrates the diagnostic arc: history, visualization, professional cleaning, targeted topical therapy, cautious adjunctive supplementation under supervision, and structured follow-up. You're likely wondering, what are realistic red flags that should make you seek immediate attention? If you develop sudden worsening of hearing or severe acute ear pain, high fever, marked dizziness or balance disturbance, progressive facial weakness, or foul-smelling discharge that's increasing rather than decreasing, these are signs you need prompt ENT or emergency evaluation. Those symptoms could indicate a middle ear complication or more invasive infection that requires expedited therapy. Similarly, if you start any supplement and notice unexpected bleeding, severe skin rashes, shortness of breath, or signs of systemic allergic reaction, stop the supplement and seek medical care.
A few practical dosing and administration notes can be helpful for conversations with your clinician, but remember, this is illustrative, not prescriptive. Many olive leaf supplements list eleuteropin concentrations and often recommend standard oral dosing ranges on their packaging. Clinicians sometimes reference these ranges when discussing adjunctive use. However, dosing should always be personalized and discussed with your healthcare provider, particularly because absorption, product quality, and an individual's medical profile vary. For topical formulations, there are specially compounded or formulated preparations that an ENT or pharmacist might recommend. But again, topical ear applications should be pursued only with explicit ENT approval to confirm an intact tympanic membrane and to ensure the chosen vehicle and formulation are safe for otologic use. If you're shopping for a product and want to have an informed conversation with your clinician or pharmacist, here are the practical markers to bring up. Ask whether the product lists a standardized eleuteropin content and what that percentage is. Look for third-party testing or certificates of analysis. Check the full ingredient list for potential allergens or additives you might avoid. Consider the reputation of the manufacturer and whether they provide transparent testing information. And choose an established retailer or pharmacy rather than an obscure seller. If you encounter a product that promises to cure tinnitus or claims to replace prescription antifungal therapy, treat the marketing as a red flag and discuss alternatives with your clinician. Another area of frequent questions is recurrence. Otomycosis can be stubborn and recurrent, particularly when risk factors remain: continued exposure to moisture, poor ear hygiene with devices, or underlying conditions like diabetes. Preventative strategies include keeping the ear dry when advised, careful cleaning of hearing aids and earbuds, avoiding unnecessary prolonged courses of topical or oral antibiotics that can disrupt normal flora, and prompt attention to itching or mild changes in the ear. Some clinicians recommend periodic follow-up for people with recurrent episodes so that any early recolonization can be treated before it becomes symptomatic. Again, olive leaf, if used, should be part of a prevention discussion only after clinical clearance, and not as a sole preventative measure in place of hygiene or environmental adjustments. Let's cover a few frequently asked questions viewers often have, in straightforward language. First, can olive leaf be used in place of ENT-prescribed antifungals? No, olive leaf should not replace prescription topical antifungal agents when they are indicated. The standard of care for confirmed otomycosis is professional cleaning plus targeted topical therapy, and olive leaf may be an adjunct at best. Second, is there a test that definitively proves my tinnitus is caused by a fungus?
Fourth, use objective monitoring, symptom diaries, and scheduled follow-ups to determine whether the adjunct seems to add benefit. Fifth, if symptoms persist or worsen at any point, discontinue the supplement and escalate care as directed by your provider. To close with honest encouragement, many people living with tinnitus feel isolated and desperate for answers. The prospect that a fungal infection could be the underlying or an aggravating cause is not a universal explanation, but it can be a real and treatable contributor for a subset of patients. That means there are actionable steps you can take. Seek a careful ENT evaluation, avoid risky self-care, choose high-quality products if you pursue supplements, and combine approaches under professional guidance. Olive leaf extract presents a biologically plausible, pre-clinically supported option as an adjunct, but it should never replace established diagnostic and therapeutic care. If you're dealing with persistent ringing, the most empowering move is to get a targeted assessment that considers otomycosis as part of the differential diagnosis. If this topic resonates with you and you'd like trustworthy resources, check the pinned links below for ENT referral directories, overviews from reputable medical societies about otomycosis, and a guide to evaluating supplement quality. If tinnitus is affecting your life, book an ENT or audiology consult, bring a clear history, and ask about the possibility of fungal involvement. And if you found this breakdown helpful, please subscribe for more evidence-minded discussions about natural approaches that are practical, cautious, and rooted in clinical reality.